At Brisbane North PHN, our vision is a community where good health is available to everyone. To help us achieve this, we support general practices in the region to deliver high-performing primary care. We do this through a range of quality improvement initiatives. This quality improvement microvideo forms part of a suite of educational videos to provide practice managers, reception staff and practice nurses with tips to implement quality improvement activities in general practice. Welcome to the Brisbane North PHN's Quality Improvement Microvideo series.
So welcome everybody. Today we're going to talk about infection control in your practice, which of course is a very topical subject given the COVID for the last 18 months. So we're going to give a quick overview from a high level, not going to dive into great depth, but I hope there's enough information in there for you to learn. So to begin with, we acknowledge on behalf of Brisbane North, the Aboriginal and Torres Strait Islanders as the traditional custodians of the land on which we stand, and we pay respects to their elders past, present and emerging. This is me, Scott Phipps. I've been around accreditation since it began and in medicine for longer than I wish to think. Okay, infection control of your practice is based on standard 4 in the GP module. If you think back to the standards, they're divided into 3 modules, the GP, the core, and the quality improvement module. So this is really important in GP world. It's all about reducing the risk of infection for you, your patients, and of course, your staff that come to work in your building. We'll talk more about that in detail as we go along. So standard 4 is divided into 6 indicators, which cover the basics that the practice needs to do. First of all, you must have a policy about infection control. There's no point telling you you're doing it on the wing, just taking it on an idea from somebody that you've read somewhere else. The practice needs a policy on infection control. That's simple requirement. You can't get away from it. And part of that infection control policy is immunisation for staff and for doctors in the practice. And we'll talk about that later when we get there. Secondly, it needs to nominate somebody who has the overall responsibility for infection control in the practice. In other words, the person who has the ultimate responsibility for executing that policy. Usually a practice manager or someone like a senior nurse, but someone has to be the go-to person. Thirdly, then there has to be someone who's responsible for the education of the clinical staff. In fact, it's for all staff in my view, because infection control is just as important at the front desk as it is out the back. So someone needs to be managing the education component, which we'll talk about. Then number 4 is the specifics that are required. And of course, that's the simple thing like PPE, sharps management, waste control, handling an infectious patient, and of course, the ever popular hand hygiene, which again, we'll talk about in detail. The 5th area is around spills and bodily fluids that end up on the floor. Somebody vomits or something delightful, bleeds everywhere. Just how's the practice managing that? And of course, the final step is the provision of sterile stock for procedures. Now, that can be simply disposable sterile stock. Many practices are going that way. Or if you do your own sterilisation on site, then that has to be managed in accordance with the principles that are laid out. So talking about principles, there are 2 major things in infection control: standard precautions, which used to be called universal precautions, and transmission-based precautions, which are really potent things at the moment, because with COVID around the country, and we're talking to you at a time when the country's beginning to open up, and so COVID will increase, the numbers will spread. It's inevitable. So standard precautions, what are they? They're the things that you need to do all the time. They're just routine, they're standard, they're something that's not out of the ordinary. Simply masks, gloves, having access to protection for yourself. Secondly, having good hand hygiene, making sure that people are washing their hands appropriately in the practice. And thirdly, that the aseptic technique, if you're doing something to a patient, you need to have a proper aseptic field from which to work. So if you're removing a skin cancer you need to be able to show that you can create a proper sterile field. It's only a miniature field compared with a major operating theatre, but there's got to be a sterile field created for doing that. And then thirdly, the disposal of waste. So whether that's clinical waste from a procedure that's been done or waste as in materials generated otherwise in the practice. And here I'm thinking particularly about tissues used by patients sitting, coughing and spluttering in your waiting room, and where are those tissues going, who's getting rid of them and how they're getting rid of them. All those simple things that we need to be talking about. Transmission-based precautions is predominantly for circumstances where you are in close contact with a patient over a period of time. So that's direct contact, touching a patient. It can be droplet contact from people coughing and sneezing and carrying on. Even loud talking generates droplets. And the third one is airborne, which is really particles of dust that pick up bacteria or viruses or whatever and settle on surfaces. So the airborne one is the one that creates all the angst, because the evidence is that certain bugs can live for a long time on airborne particles settle on a surface. And if those surfaces are not being cleaned properly or adequately, then you could have a contagious surface. And some bugs can live for an alarming amount of time. The important point is down the bottom there. Both principles always apply. Standard precautions are just what you do all day, every day. There's no getting away from that. Transmission-based precautions are applied where it's appropriate. So in practices that are doing simple procedures, skin excisions, whatever, they need to be thinking about transmission-based precautions because you're close to a patient. We'll talk more about that in detail. So here we go. How do you really apply standard precautions in your practice? The important thing is think about simple things. Don't make it too complicated. You can see there the first thing is triage. This is in terms of scheduling of appointments, really important for general practice. Do you really need to be mixing those elderly people coming in to have a skin cancer removed with other people who may be potentially contagious? So a little bit of thought needs to go into managing how you arrange appointments, what timing you're using, what you're doing. Secondly, then, of course, we've got the spacing requirements in surgeries. A lot of people request to stay outside, to wait outside rather than coming in. If you've got adequate room and you can space the chairs, then you put them in 1.5 meters apart. Thirdly, respiratory etiquette, which is a nice way of saying we don't want people coughing all over you, your staff, or anybody else. And of course, most of us now have perspex screens at the front desk, but these are not difficult or complex concepts. They're very easy to think through. PPE, well, absolutely, we all know that. It has to be done. But of course, PPE has to be put on and removed. So don and doff procedures have to be done correctly. And there's plenty of evidence from around the world now with COVID that people start to get tired by the end of their shift and they begin to make mistakes. You know, they take the gloves off at the wrong point of the cycle or whatever. And so all your great work could just go straight down the gurgler because you make one mistake. We're not in that sort of situation in general practice the way they are in hospitals, but most hospitals now are using buddy systems where people watch each other to make sure that they're not making mistakes as they get tired by the end of it. Hand hygiene, it's still the number one problem in infection control. The studies are just everywhere. It's mind-boggling that we still have to talk about this in healthcare, but hands are the chief area of contamination because we touch surfaces, we touch people, we touch whatever. We pick up bugs, as I said before. They're out there, they're floating on dust particles, they're landing on surfaces. If they're not being adequately cleaned, our hands get contaminated very quickly. So hand hygiene is all about the 5 moments. It's not just a matter of do you wash your hands. I don't want to spend a lot of time talking about the details of the 5 moments, but it's important that hand washing is done correctly. So remember last year, all the promotion was you had to wash your hands for 20 seconds and you had to sing happy birthday to yourself twice. That's all fine, provided that you observe the timing. So the 5 moments are all about the timing of when do you do your hand hygiene. So you've got to do the process correctly. It's not practical in most general practices to have an audit of hand hygiene because they're small places with only a handful of patients, but handful of clinicians, but it is certainly something that you can look at. Education, 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 refreshers. We all get into bad habits. We think we're doing the right thing. We think, oh, I don't have to do that. It doesn't apply to me. Yes, it does. It applies to every one of us, and we have to do it correctly. So the college has brought hand hygiene into the standards because it's critical. Environmental cleaning, straightforward. Surfaces, as I said, they've got to be cleaned with an approved agent. So it's no good just getting a bit of domestos from down the supermarket down the road. That's not an acceptable cleaning agent. It's got to be properly approved, the cleaning agent. Making sure that the surfaces are being cleaned regularly, making sure that things get wiped down as they should. And then, of course, you've got the obvious ones there in the environment, the sharps, the clinical waste and so forth. That's bread and butter for general practice. And I'm not going to get into a discussion around what constitutes clinical waste. The simple answer is if you've got blood on something, it's clinical waste. I mean, yes, we can argue that it's not technically a risky item at that point. Doesn't matter. Just use the yellow bins, people. Put it in. It's quite straightforward. It's simple. Don't make it complicated. Don't end up in arguments that really don't go anywhere. So standard precautions, that's what we're all doing all day, every day, second nature, nothing to talk about. Transmission-based, as I said a minute ago, there you can see there the 3 essential ways that it moves. So how does this play out in a practice? The obvious thing is you have to restrict access. You can't have patients wandering. You shouldn't have patients wandering all around everywhere in your surgery unless they're being accompanied to go to a particular procedure room or wherever it is. So the first thing is, I mentioned the triaging of your appointments. Think about how you can stagger appointments. Just maybe reduce your numbers a little bit, but don't have people crowding in that have to be seen in the next few minutes. Restrict access of people. Think about staff. Where are they going? What are they doing? Does that reception staff really need to go down to the procedure room for whatever? Think about the placement of your stock. If the reception staff want to go and get reception equipment and stock, do they really have to go to the procedure room to get it? So in other words, think broadly around how your practice functions with the flow of people, because that's where the bugs are going to go. The bugs follow the people, therefore you need to follow the bugs. Think about the procedures you're doing. Are we doing procedures that could place us at risk? So if you're doing some skin excisions and you're up close and personal with somebody, then you need to make sure that you're aware of the concepts around transmission-based precautions. This is to protect you much more than is to protect the patient. In the olden days, when I was a boy, we wore masks to protect the patient. Now it's the other way around. We're protecting ourselves. So think about the procedures you're doing. Think what is appropriate for you. If you're doing sclerotherapy or you're doing, as I said, skin excisions or whatever, where you are dealing with a patient contact over a period of time, you need to be a little bit more aware. Think of the equipment that you're using, just making sure that that equipment is cleaned appropriately. So again, if you're touching patients with something over a period of time, making sure it's been adequately cleaned down. One of the common ones is the hyfricator machines that are up on the walls in the procedure rooms. Do they get cleaned? Does anybody actually bother to go and clean them properly? You know, they get the tips and do things with that, but do they clean the rest of it? Have you got plastic covers over your cords that you're touching? In other words, think broadly, just take a little step back. And of course, the infection control policies and so forth, you need, if they're appropriate to your practice, you need your transmission-based precautions covered by your procedures. There's no point in saying, well, it's all covered in standard, because it's not. It's got to show that you've been thinking about it moving forward. So good old PPE, everybody should be well and truly on top of all of this. The most important thing is you need to wear it. I go to plenty of practices where people are not wearing the PPE when it's appropriate. It doesn't mean you have to run around all day in PPE, but you need to be thinking about what job you're doing and what's the risk of exposure. Something to cover your eyes. It's strongly recommended now that you wear face shields as opposed to goggles. It's a personal choice, but the face shields are certainly showing to be more effective. Surgical masks, you only need the basic surgical mask for normal contact. N95 and P2, look, you do not need those for an everyday contact. They're recommended where you've got a prolonged contact or a high risk. So if you get notified somebody's coming to see you and they've just been discharged from quarantine 3 days ago and now they're feeling a bit crook, well, that might be the time you want to pull an N95 out of the cupboard because that person could well have COVID. So it's a matter of thinking of the likelihood of this person being contagious. The problem is, of course, we've had very little COVID here in Queensland. So we're gearing up now when the borders open, we're going to have a flood of it. So we're going to have to be much more cautious about who we approach and how we approach them. So what I'm saying is surgical masks and shields, by and large, all you need. It's a good idea to have a box of N95 in the cupboard so that if you need it, they are prohibitively expensive if you start using them all the time, and that's fine if you can afford it. But for the vast majority of things we do, you only need the simple mask. So it's all about contact. And remember, it's back to putting, donning and doffing, getting the things on, taking them off in the correct sequence. And that's back to the education, making sure everybody knows and practices their sequence. Because unfortunately, you only have to make one mistake with your doffing and you could certainly contaminate yourself, and hey-ho, you take that home and away we go. So just take your time, practice and think it through. Sharps and clinical wastes, very simple. We all know about it, yellow bins everywhere. The rule, of course, is whoever creates the sharp gets rid of it. So we don't want nurses finding unexpected sharps in trays of instruments. They should be disposed of by whoever was using it. So whoever was the surgeon involved or using the sutures or using the needle or whatever, it's their job to get rid of it, not leaving it for somebody else. The bins obviously need to be available everywhere. So we all have our little yellow bins for the sharps. We'll have our big yellow bins for the contaminated waste. The yellow coating is universal. The wheelie bin's got to be locked. That's a safety precaution in case somebody decides to go burrowing around in the bin. Goodness knows what they're looking for. But of course, there are people looking for syringes and needles and heavens knows what. So you must have your bin locked. It is your responsibility as a practice to make sure that the bin is secure. The dreaded needle stick, look, that's going to happen. It's inevitable despite all the education and all the procedures we go through, telling people not to recap and not to do this and not to do that. It happens. And even when they've done the right thing, it happens. So the practice needs to have an easily available protocol. Best is to have it up on the wall to say, if you have a needle stick injury, this is what we do. Following steps 1, 2, 3. It needs to be quickly and easily available because people get understandably upset. They've had a needle stick and they're maybe not able to think clearly about what my next steps are. So you need to have that there. Everyone needs to understand it's important. Spills kit, absolutely, but does everyone know how to use it? I mean, I know that sounds a bit strange. They'll say to me, oh, the spill kit's in the cupboard. And I say, what's in it? Oh, might be some kitty litter, I think. I'm not sure. So there's no point having a procedure or having equipment or having whatever if the staff don't know how to use it or what it is. So making sure that everything's there, because that's a key responsibility. All this infection control stuff, key responsibility for the practice. You have to provide a safe working environment for your staff, the doctors, and absolutely safe working environment for the patients and carers that come in. So we cannot pass the buck on this one. Environmental cleaning's become a big issue, as I said earlier, so the airborne materials that settle with it. So the questions here are really important. I mean, if you've got a contractor that's doing your cleaning, how do you know that they're doing it correctly? How do you know that they're doing it with what's the current processes? They might have been a cleaner for 25 years, but they're doing things that were done 25 years ago when they learned and not necessarily have kept up. And secondly, the agents that are used, I mentioned earlier, you don't run down the road and get a bottle of Domestos from the supermarket. You have to use an approved agent. So making sure that what they're using is appropriate for your surgery. And of course, as part of that, we all have to provide the safety data sheets, as they're called, which is a description of the materials that are being used and the correct handling of those materials. Now, if you have a contractor, they usually have all that available because that's their responsibility, but it's useful for us to have information around the agents that are being used and therefore the correct handling from our perspective. If they happen to leave a bottle of it in the cupboard and somebody decides they want to go and use it, well, hang on, you need to make sure the information is there. Interesting one is the deep clean, which many practices haven't thought about, and that is you go into a consulting room, there's a nice open bookshelf with lots of lovely books there, and most doctors love their old books and they think, this is great, I can pull this down and show someone a drawing or a photograph. The problem is that if you do a proper deep clean of that room, if some contaminated person comes in with COVID and the room has to be cleaned out, the materials used will basically destroy your books. You will not have much left at the other end if it's done properly. So the advice is very simple, which is keep your rooms bare, put the books in a cupboard. You don't have to get rid of them, but it's got to be in a closed place or put doors on front of the bookshelf or whatever. I've seen places that put a heavy-duty plastic sheeting on that's held down with Velcro. I mean, it doesn't look the greatest, but it saves your books. What I'm saying is you need to look at your environment a little more carefully and think about, if we've got to do a deep clean in this place, what's the stuff that we're going to have to sacrifice, and do we really want to sacrifice it? So all those lovely chairs you might have and children's toys and all sorts of things, think about what's the important stuff, because it's likely to be destroyed by a proper deep clean. So I'm not trying to be Mr. Pessimistic here, but unfortunately this is going to happen in Queensland once we start having an outbreak. Can't say it often enough, hand hygiene, hand hygiene, hand hygiene. Just look at it. There are online modules. There's a whole association of Hand Hygiene Australia, which runs all this stuff. It's just huge. It's enormous. People contribute data to it, which they do their audits of staff members to see if they're doing their hand washing properly. Most times that's not going to apply to practices, because you need a decent number of employees to be acceptable to Hand Hygiene Australia for the data to be reliable. The whole key point is, though, we need to be thinking about this. We need to be considering the 5 moments, looking at when we should be doing it, and online trainings, as I said, is available, but training within your own practice, it's really good to have a little bit of discussion, get it going, get people talking. Education is really important. And the second thing is we all fall into bad habits. So somebody doing an audit, just having a look, watch me wash my hands. It might be a bit off-putting to begin with, but it actually is a jolly good point for it, because it's protecting you as much as it's protecting your family, and it's protecting, of course, the patients and the other staff members. So remember that a surgical scrub is 3 minutes. So when we go into theatre, it's a long time scrubbing your hands, and we use medicated soap. We don't expect that, as I said earlier, 20 seconds, hum away to yourself. Remember that alcohol rubs don't kill norovirus very effectively, the thing that causes terrible diarrhea cases around the country. In the hospitals, there is a bit of a convention that you do so many hand washes with alcohol and then you do a proper one with soap and water. The evidence is that soap and water for 20 seconds, and I stress for 20 seconds, is effective, because it removes that top oil layer of your skin, which is where the bugs are happily settled and waiting for an opportunity to infect somebody. So look, hand hygiene, it's amazing. We still deal with it. We still struggle with it. And it's the #1 risk. Okay, you've heard me say several times, education. It's really important that you make sure practices are educating their staff. And that's everybody. I mean, the doctors, the nurses, the baker, the candlestick maker, everybody involved, because we get bad habits, as I said before, or you get different ideas, or you get something that was in vogue 5 years ago, and that's not necessarily what's being done now. So what the assessors need to see is that the practice has the nominated person, as I said, someone who's in charge of the education. A small practice, that'll be the same person who's the head of the policy. But in a large practice, you can divide that up quite easily into 2 different roles. And the key one there is, to whom are you presenting? My point again, everybody. It should be everybody. Infection control is too important. It's something that we have done not well in general practice. Over the years, we've become a little bit lax in healthcare because we've relied on antibiotics and thinking that we'd conquered infectious disease. And of course, Mother Nature's now throwing COVID back at us. And so we're learning very quickly we're not as smart as we think we are. So we all need education and revision. Immunisation, I'm not going to talk about the pros and cons of compulsory immunisation. That's a whole different argument. The point is that the Australian Immunisation Handbook gives you the information as to what's recommended for anybody working in healthcare, in particular criteria. And of course, there are state jurisdictions as well. I say to people, have a look at the Q Health recommendations. What are they recommending for their staff? It really is a difficult area because the issues around vaccination are becoming more complex as time goes on. So I'm not going to spend time arguing the pros and cons. What I'm saying is that Delta variant is certainly so contagious that we need to be protecting all of us together. So you look at the risks that you have amongst your staff. So that it's important for practices to remember they are there to protect their staff. And this has actually now come under workplace health and safety. If you have staff members who are being exposed to potentially infectious agents, and the classic is rubella, and somebody might be pregnant, then, have you taken steps to try to ensure as best as you can that they have their rubella vaccination up to date and so forth. The point about it is that the practice must offer the range of vaccines that are recommended. It's not advisable for a practice to make its own decision. It can, but it would have to have a very robust risk assessment. It would say, we're not doing these vaccines because ... and give the reasons why. The reason I said it's back to workplace health and safety. There's been a couple of cases where people have contracted contagious illnesses in a medical practice, and legal cases have been taken because the lawyers discovered, hey, there's a vaccine for that. Why wasn't my client offered the vaccine? So we don't have to be ruled by the lawyers, but it's the real world in which we live. So the bottom point there is the key thing. A person has the right to refuse a vaccine. Putting COVID aside, a person has the right to refuse a vaccine, but what must be documented is that the practice offered the vaccine to the patient, to the staff member, whether they offered to pay for it to be given somewhere else or whether they offered to actually have it done at this practice doesn't matter. It's a matter that the offer was made, it's documented it was made, and the refusal was documented. Because if you don't have that, then you have no evidence to confirm your point that, oh yes, we offered it to them, but they chose not to have it. I don't want people to get worried about the lawyers, but you do need to understand where these things come from and how they come about. So immunisation, a key and critical point, which we're all aware of these days with good old COVID. Sterile stock, the key point about it is that anything that's reused in the surgery has to be shown to be appropriately sterilised. So reusable instruments have to go through a sterilising process, whether that's done on site in your practice or whether that's done somewhere else is not the issue in the sense that it all has to be done appropriately and in accordance with current guidelines. It's one of the biggest stumbling blocks that people have with accreditation is that sterilisation, the processes evolve over time. And so what we're doing now is quite different to what we were doing, say, 3 or 4 years ago. And you do need to keep up. Most important thing there is to remember these days that a tracking system is needed. The standards say we should have a tracking system. In other words, you can confirm what instruments were used on a particular patient, and then you can go back to see the evidence from that particular sterilising cycle, that the sterilisation cycle was completed satisfactorily and that there was no problem. The other point about reusable instruments is they must be stored correctly. They are in paper bags. Paper and water do not mix. So if they get wet in any form or shape, you've broken down the sterility. The biggest problem or the commonest problem with that is people put them up in shelves and up the top, and the shelf sitting under a air conditioning vent that's got the occasional drop of water coming out of it. So they may not be obviously wet, but there's water getting onto the bags, and of course the sterility is broken. So they should be stored in cupboards with closed doors or in drawers or something well away from any possible contamination. Disposable instruments are much in vogue. A lot of practices are choosing to go that way, no problem, just making sure that the disposable instruments are in date. There is a date on them. It's usually a fairly advanced date, but you don't want to be using instruments that are out of date. Thank you very much. I'm not going to spend time on the pre-cleaning or the cleaning. It's just be aware, as you all are, I'm sure, that there's a very clear process, protocols around cleaning reusable instruments that must be followed. And training for the people doing this needs to be documented. You need to see that they've actually had a heads up, they've had a proper introduction to the process. And thirdly, you need to validate at least once a year of your machine. And fourthly, you need to make sure that the cleaning, maintenance, all those sort of things are properly maintained. It's one of those simple things, but it can be rather complicated. And I tell you, it's a significant stumbling block for a lot of practices. So that brings me to the end of my presentation. You can see there's a number of references for you. The Australian guidelines are there. The RACGP has their guidelines. They're everywhere. Each state is different in terms of their jurisdiction, so you may need to check with that. But overall, the Australian guidelines are universal pretty well everywhere and acceptable. The most important thing, folks, is to remember infection control is a key pivotal role, something we cannot push aside or do in a second slipshod manner. It's too important. Thank you.
This microvideo is supported by funding from Brisbane North PHN through the Australian Government's PHN program.